slow down a bit. Great. Hello, everyone. I am very delighted to introduce Don Juzwishin today for our talk. Don is a faculty here. He teaches quite a few of our courses, but Don has an incredible amount of experience and knowledge in the area of health informatics. A little bit of a background about Don. Don has about 40 years of experience in global, national, provincial, and local healthcare administration, research, consulting, and education. He has areas of interest that include effective application of science and values to inform health policy decisions, healthcare reform, and informatics. He specializes in the creation and application of technology assessment to inform decisions of clinical cost, effectiveness, and in terms of healthcare interventions. Don is also the editor-in-chief of Healthcare Management Forum, and his work package, he is the lead for the work package in Age Well on aging networks. Don also currently leads the Healthcare and Service Delivery Challenge area for Age Well and is the chair of the Alberta Genome Canada Research Oversight Committee. Don was the director of the Health Technology Assessment for Alberta Health Services, the Alberta Heritage Foundation for Medical Research. He served as executive director of the Health Council of Canada. He served on boards of the Canadian Coordinating Office of the Health Technology Assessment, the Canadian Society for International Health as director and treasurer, Health Technology Assessment International as treasurer, and he has served as a member of the Alberta Advisory Committee for Technology. Don has been a technical committee and leadership has been doing quite a bit of technical committee leadership and governance in terms of working groups in the health standards organizations, updating standards for Accreditation Canada. Don is also an adjunct professor at the University of Alberta and adjunct professor at the University of Calgary. Today, Don is going to talk about unlocking Canada's health data challenges and opportunities, and he is going to give us a wonderful talk. On that note, I will pass it over to Don.
Well, thank you very, very much, Elizabeth. This is a topic of great interest to me and has been over the years, and hopefully it will be to the audience as well. So pleased to do this. I'll start with the land acknowledgement, acknowledging and respecting the Lewankan, Songhees, Esquimalt peoples on whose territory the University of Victoria stands. Elizabeth, thank you for identifying that in the introduction. It is cutting into my time, but I will also say that I am retired. However, I do have a lot of interests. I have no conflict of interest to declare that I can think of, but I do attempt to stay involved in many of the contemporary issues associated with health, public health in Canada. The objectives today, I want to identify why Canada is a laggard in liberating its health data to Canadians. And by being a laggard, it contributes to the creation of harm to Canadians and to the dysfunction of the delivery and performance of our health system. And I won't leave it just at identifying the problems. I will try and identify some of the ways forward as well. So the key to unlocking Canada's potential, the problem with the key is it always opens the gates of either heaven or hell, or both at the same time. And if you identify the key, which I would suggest is data, health data, it will be necessary to appreciate that data alone will not address many of the issues that we face as a country, but we also need collaboration, cooperation, consensus building, standards development, collaboration, teamwork among citizens, government leaders, industry, and the academic communities of which you and I are part, Elizabeth. So if we look at a historical context, we've had innumerable royal commissions, task forces, and reviews over the years since 1964, which I'll use as a starting point, which kicked off the delivery of physician services in 1968. And then, of course, we had the new perspective on the health of Canadians. The Lalonde Report brought to the fore the concept of social determinants of health. We have the Health Services Review, which looked at elements that contribute to high functioning. The Framework for Health Promotion, Jake Epps' term as Minister of Health, basically identified the Achieving Health for All paradigm. The National Forum on Health, 1994, focused on the informatics side of things and the creation of evidence to help inform really effective delivery. And of course, we had the Kirby report and the Romano Commission. The Romano Commission trying to bring to our attention the fact that the values of Canadians were much more communitarian, that were being reflected in the way healthcare was being delivered. But let's just focus on the 90s, the evidence and information, which was volume 5 of the National Forum on Health. And you'll see here from the tables of contents that individuals like Paul Fisher and Marcus Hollander from our faculty here at the University of Victoria had a chapter on decision support tools in healthcare. The first chapter was on factors that influence evidence-based decision-making. And then Charlene Black from the University of British Columbia, formerly from Manitoba, did a chapter on building a national health information network. And of course, Carol Kushner and Michael Rackless reviewed strategies to increase consumer involvement in health policy involvement. That was 30 years ago. And we are in the midst of a situation today in which we have serious problems. So why is it? First of all, one could characterize the challenges as being foot dragging and obfuscation, political chest thumping by government leaders in attempting to move the agenda forward. However, there seems to be a lack of political will to challenge the status quo. Oftentimes, we see knee-jerk reactions to give the impression of action, but there is no long-term planning or implementation. There is protection of power, ego, and influence that is at stake in some of these cases. There's disagreements over minutiae, childish tantrums, fiscal constraints, political posturing, parochialism, populist nationalism is making a big impact today all around the globe. Or perhaps something as simple as just ignoring, misinterpreting, or not understanding the multitude of data that we already have. So knowing that that's the environment that we're in, is there a better way? Well, we've just emerged from a global pandemic. Global temperatures are at a record high. Floods and fires abound. Alberta has 57 fires going on at the moment. They are under control. Chile has 161 fires in the Southern Hemisphere at the moment. Economic capacity and sustainability are stretched. Mental health issues abound. Nvidia just hit $2 trillion on the market capitalization. You would think that these would bring Canadians together and preserve what we have achieved. And I'll come back to the $2 trillion market cap towards the end of the seminar. So Canadians had great pride in their healthcare. I remember all through my undergraduate years being very, very proud of the fact that Canada was able to position itself highly. But today we have 6 million Canadians without access to family physicians. Primary care, it's absent. High staff vacancy rates, long emergency department visit waits, surgical wait lists are long. We have acquaintances and friends that are going south of the border, or they're going to Bulgaria, or they're going from Alberta to Ontario to have their hips or knees done, while Ontarios come to Calgary to have their hips and knees done. And we have cataracts all being paid for out of people's pockets, which is supposed to be within a healthcare system that is supposed to be publicly funded. How does this happen? Health disparities on a broader population context appear to be increasing. And knee science is at a zenith. So let's just look at some aggregate data for comparative purposes across the country. So when I was at the Health Council of Canada, we partnered with an organization in the US called the Commonwealth Fund. And the Commonwealth Fund has been doing a comparative analysis of the performance of healthcare systems, particularly those OECD countries, over the last 14 years. So let's just look at a snapshot of some of these. So here we are in 2010. Out of a group of 7 countries, we ranked number 6 in overall ranking. Now, the indicators that are looked at were quality of care, and you can see that quality would have been defined by the effectiveness, which means, are you achieving the goals that were identified in the care process? Was it safe care? Was it coordinated? Was it patient-centered? And access was also a dimension, as was efficiency and equity. You can see that the United States, of course, was number 7, and you can see at the expenditures at the bottom of the page that we weren't the second highest. We were the second highest expenders at $3,000, but we were definitely not getting the kinds of outcomes that would have been anticipated. Let's jump forward for 2014, and you can see that now the list has been increased to 11 countries, and we hold our position as being the second worst in our performance. And you can see in those categories where we're weak and where we're stronger. In 2017, 3 years later, we hold on to our race to the bottom. France actually beat us out in being the second worst. So we came in at number 10. And in 2017, we've got a sort of graphic display of this showing those countries, the 11 countries above average in terms of their system performance. And of course, Canada being third. It was in 2021 when we regained our place in second from the bottom again, and France moved up to number 8. Now, you can gain access. I provided the URLs for all of these reports, and so you can gain access to these quite easily and be able to look at the detail as to how the dimensions associated with these criteria were actually pulled together. Suffice it to say, it's not a record that we can be at all proud of. And there's several reasons why that would be the case, which I'll jump into. But before we become entirely nihilistic about this, we have choices that we can make as a country. We can try and hold our own and hold the position of being the worst, second worst performer in the OECD system, or we can throw in the towel and basically go for private funding and private delivery and let the system simply compete for number 11 with the United States. But remember Judge Steve's judgment from the BC Supreme Court, which unequivocally, after 800 pages of analysis, identified the fact that publicly, universally accessible healthcare systems provide far better care than do private funded systems. Or we can pull ourselves together and try to establish a position in the top 3 healthcare systems of the OECD. So I'm going to suggest how we might be able to do that. First of all, the aggregate numbers that I shared with you earlier wash away the anguish, the suffering, and the harm that individuals experience. So I want to recount 3 stories for you. That of Ewan Affleck, acting on behalf of Greg Price, an Albertan who died several years ago. Claire Sinman, who I will introduce her experience to you. And then Andrei Kushnerek, who is the director of our Health Information Science program here at the University of Victoria. And I'll just talk a little bit about his experience and his story. Bottom line is, all of those stories are going to demonstrate that data information and evidence are an important currency of all care development. And we're not in a very good position of distributing that to Canadians. So the first thing I'd like to do is talk about Ewan Affleck's work. So he is a physician who has practiced many of his years in Northern Canada, in the territories, Nunavut, and the Yukon. And that experience demonstrated to him how important it was for data to be easily accessible and available to him in delivering care in an area that did not have technology with it. And he's currently a senior medical advisor in health informatics with the College of Physicians and Surgeons of Alberta, although he does still continue to practice in the North. And the North probably has one of the most comprehensive informatics platforms as a result of some of his work in that area and leading that session. I would advise any of you to witness his YouTube video of a seminar that he presented to the John Dossiter Health Ethics Center back in September. What he does is he describes the experience of Greg Price, whose cause of death was the lack of health data interoperability. Young man, and from the day that he had his first clinic visit to the day he died was a transpiration of 462 days. So you can see there on the left-hand side that Greg enters the system and he's in contact with laboratory for testing. He's had an interface with the emergency room. There's interventions as well between the prostate clinic, urology, lab, etc. But Greg got lost in all of this malaise of information which was not being transmitted between elements. Albertans will know this story quite well. And the Health Quality of Council was then commissioned to do a review of what went wrong that caused Greg's death. And what they identified was that essentially our healthcare systems in this country are legislated to be fragmented. There's no intention to have interoperable capability amongst these various elements. We're still based on a paper-based system, and our legislation and our policies and practices are generally oriented towards a system from the past, rather than facilitating opportunities that present from opportunities of interoperability with the internet and communications. So with this kind of failure, we have a lot of work to do. And when you think of the various elements that contribute to health data's organization and delivery within this country, there's the responsibility for governance. Well, we failed at that because we don't have anybody in charge of health data. Legislation and policy still reflects an antiquarian perspective, as do regulations. And regulations of a technical component are still reliant on, in many cases, approaches around when you can fax information or carry it or transmit it to another area. Data literacy as well is at a point in which there's much work to be done in improving the understanding of individuals in the workforce, as well as in the public of the health data. Communication is difficult, and there's a culture of trust or mistrust that exists as well that we need to address. So when Ewan drew up this diagram, he identified all of Greg's challenges, and then on the right-hand side identified how we did harm to Greg. First, there was the emotional and physical harm. He died. There was no breach of privacy or security. That was all fine. In fact, privacy and security were the least of our concerns. Breach of cultural rights was not an issue. He had consented to all of his information being available to whoever it was necessary to make available to. Breach of legal and ethical rights. His ethical rights were breached. The information, his health data, was not utilized to preserve his life. Population harm is much broader, but system harm, can you imagine the money that was wasted in the transactions that took place and the interfaces that took place without having had any positive impact on Greg's life? So those resources could have been utilized to improve care. And the harm to workforce well-being. Individuals working in the workforce are finding it extremely frustrating to not be able to have a full patient history or laboratory results, etc. And some of you might recall that Atwal Gawande publishing an article in the New Yorker, identifying why doctors hate computers. And yet, when computers first arose, they were identified as a salvation to being able to facilitate care delivery. So within the health data construct, we recognized that we need to have health data optimized, and we need to do that through technical factors. And this is not so much a technical issue as it is issues associated with human factors. We need to be able to have common data standards, common user authentication, internet connectivity, and common data standards. So progress is being made on those areas, but those larger human factors are what are going to have to take our attention in the next little while. So my second story I want to tell you is that of Claire Sinman, a young woman with a young family in Vancouver who arrives at the emergency department with a headache and is diagnosed with a brain tumor and told that she ought to simply go home and wait for some further remedial action. Time passes and she has multiple linkages and relationships with different clinical providers, as well as individuals that are attempting to be helpful and some not so helpful. She's written the book, 2 Steps Forward, which essentially documents all of the steps that she went through and the misadventures she experienced on a daily basis as a diary of her experience. She has done a YouTube video describing her interactions with the healthcare system, and I would highly recommend you taking a look at it, and the URL is there for it. The last chapter of her book is titled Being Your Own Body's Advocate. She suggests that everybody take responsibility for their health and their interactions with the healthcare system. As she says, you're trying to fight for your life with a brain tumor, and yet you have to be the manager, administrator, the patient, or even a caregiver if you have a family member that you're looking after. And that's at the same time that you're trying to deal with your illness. She also thought that the health system had her back. She realized that that was not the case. She was wrong. There were too many silos of good people working in opposite directions. And so she developed what she calls the team approach, and that is to track, educate, ask, and manage. But it's hard to track, educate, and manage when you actually don't have the data, when you don't have the information and the evidence that you can have easy access to be able to manage your affairs. The third story I want to recount is that of my colleague, Andre. So Andre had several visits to his dentist, and a tongue cancer that was developing went unnoticed. And so he began this journey of interacting with clinicians and with the healthcare system in a fashion that left him with long waiting times, wrong information, advice, and understanding of what was necessary to treat his cancer. His physician essentially told him he should now prepare for palliative care, which mobilized both Andre and his wife to begin to look at what evidence is there in the literature that would suggest that this is a condition for which I ought to prepare for palliative care. And what they found was that there actually were alternatives of best practices, not currently in Canada, but in other parts of the world, in New York actually, which would be able to treat his cancer. He did get the cancer treated, and he's probably watching this webinar. And the point being that Andre published his experiences in an article called "The Importance of Health Information on the Internet: How It Saved My Life and How It Can Save Yours." So just as with the story that Eva and Greg brought, or that Cynthia brought, Andre as well encourages the necessity for accessible information that's evidence-based be available to individuals so that they can make a decision as to what would be the best possible pathway for the treatment course for them. He talks about there having to be an improved e-health literacy with technical skills and reasoning. Now, he would suggest that if you cannot interpret a survival curve in association with treatments that are recommended for you, then get somebody to help you understand those in respect to the different interventions that are suggested. Because having informed management, recovery, and outcomes requires that kind of insight and information. And Andre was fortunate enough to have Elizabeth help him walk through that. And as Andre points out in the article, there were many human and technical barriers that he had to face, as well as human-related factors. And there's also a necessity that Andre found important in that there is a community of individuals that actually are support to one another in respect to letting other people who have just been diagnosed understanding what their prognosis is and what the alternatives might be. So we pay our taxes to create new knowledge, and then we pay again to get access to that knowledge. The message here is, why is it, other than Andre being at the University of Victoria and having privileged access to information on the internet, the general public in Canada does not have that kind of access to information. So I'm proposing that there be a strong promotion and support for open access publishing. We ought to be encouraging an open science movement. We ought to be driving and improving citizen health literacy from kindergarten all the way to postgraduate school, so that our publics are well informed and that we facilitate more of citizen science. And the reason this is important, this is Bob Evans, health economist, retired from the University of British Columbia, just passed away last summer. But he pointed out in an article in 2022, the apparent desire for high levels of certainty by both scientists and political decision makers made early action impossible, as the data needed were not and could not be available in time. So we're talking here about the pandemic and the commitment of politicians to follow the science in times of epistemic uncertainty. And this leads to an argument for changes to the institutions that provide scientific advice based on sociologically informed expectations of science, in which expert judgment plays a more significant role. So if Bob were still here, he would probably have written this book, which G.F. Mulgan wrote. And this book describes the dynamics that take place between science and government in a historical context, but also in the contemporary context of just having come through the pandemic and potentially facing another major issue down the road with many of the issues of climate change that we're facing, as well as with the creation of generative AI and its advancement. And he gets into the description of the master and servant relationship. And the conclusion he reaches is there should be a balanced, respectful partnership between both of those worlds that is driven towards collaboration, leveraging technology for the best common good. But that has to be achieved through appropriate, responsible regulation. And that all of us on this call, for example, are responsible as intermediaries to try and bridge that gap between what the science tells us and what it is that's being interpreted into policy. So we do need to build a productive alliance. So let's agree that the dimensions of data important for public health, clinical services, look after our patients, population health, to be able to understand health disparities, public health, research, administration, and administration. We need a vision of what we must aspire towards. Let me introduce you to Dr. Vivek Goel, the president of the University of Waterloo. At the end of COVID-19, he was commissioned by the Canadian government to undertake a review of why we have such a miserable state in respect to health data in this country. Can you come up with a pan-Canadian health strategy, Dr. Goel? And that's what he did. Over the next 2 years, in 2022, the pan-Canadian health data strategy began to take shape. And I might just mention that Ewan Affleck was part of the group that worked on this. And the objective was to empower individuals with their own health data, enable clinicians to deliver care, use health data to improve public health and healthcare delivery, and prevent future threats that might be emerging. So there were 3 reports that were produced. Report number 1 looked at the root causes. What are the challenges? And what he identified were systemic barriers that obstructed success through misaligned incentives, poor understanding of health data, and failure to engage the public meaningfully. So report number 1 came up with a vision and common principles. Report number 2 began building Canada's Health Data Foundation. So what do we need to kind of bring this together? Well, we need to work together, align our public voice, governance policies, standards towards decisive action are necessary to achieve better outcomes for individuals and all communities across Canada. Excuse me. Okay, sorry about that. So those elements of the second report identify government stressed policy interoperability and capacity literacy efforts that are to be committed to. And the model that they landed on is called the learning health system. And in a learning health system, you can see in that diagram on the right-hand side, learning health system pillars involve the core values. These were all identified in the Romano report. Those all have to be then connected to the processes. So we've got data management, knowledge management, and change management taking place within our healthcare delivery organizations, as well as the provincial jurisdictions in which that care is being delivered. Ultimately, a learning health system wants to have an excellent patient experience, an improvement in the provider experience, healthcare costs being minimized, so there's efficiency in the system for the maximum benefit, which is what we get as value, and that in fact we can improve the population health as a result of that. So how are we doing since Dr. Gold released his report? Well, in November 22, when the federal, provincial, territorial ministers of health met here in Victoria and were hosted by our Minister of Health, the talks broke down. They were abandoned. There was no opportunity for any common ground for agreement on how to move the agenda forward. And a lot of this was based on funding. It wasn't until October of 2023, when the health ministers got together in Prince Edward Island, they began to reach a consensus. And things had gotten bad enough in terms of access to family practice, with access to emergency departments, that everybody agreed that yes, the health workforce did need some attention, and we needed a response to that. There was also an agreement that we needed a digital health and health data charter to be developed. And mental health and addictions and public health priorities would also be worked on jointly. So what was the Canadian Health Data Charter that was arrived at? And we know that the privacy commissioners across Canada have urged developing a pan-Canadian health data charter in order to provide a reasonable, overdue starting point for dealing with those challenges that we identified in our previous 3 stories. It's been said that it's privacy and confidentiality that has been the biggest element holding up progress. But in fact, it is the commissioners on privacy that we're trying to encourage addressing these kinds of challenges. So the health data charter suggests that any approach had to be person-centric. We needed to have common standards. There had to be secure, private, and robust approaches to the health data. Timely access is all points of interface in the system. It's to be used ethically. It's to drive innovation socially and technically. It's intended to increase the literacy and understanding. As Claire pointed out, how can you possibly manage your trajectory in care if you don't understand what it is that's happening? And there is a necessity for harmonization of governance and policy, even within the provinces, as well as across the nation. And Indigenous peoples and diverse inclusion are also important elements of that. Am I hopeful? No, but nihilism is not an option. So we know that political scientists have identified the federal government has largely retreated over the past 2 decades from country building, both in terms of political effort and institutional capacity. Canada remains distinct among federal nations with respect to the primacy of its provinces. The federal government can use its discretionary powers to steer investments with clear goals and targets. And so when this observation was made in the early 2000s, I think we've now moved a fair distance to be able to appreciate that we need to find ways to collaborate and work together to get back into country building. Because as Bob Evans said at one point, we can hang together or we can hang apart. And it's a lot more fun to be hanging together than independently. So what can be done? Stephen Lewis, adjunct at the Simon Fraser University, published this article in the Star Phoenix. The title of it was "A Long Shot Lawsuit Might Improve Canadian Healthcare." And what Stephen is arguing in this is that, if the governments are not prepared to protect us Canadians, and if our organizations are incapable of responding to the challenges that are out there, maybe we ought to have a class action suit motivated by the 15 to 20% of residents who have no family physician, motivate them to undertake a class action suit in each of the provinces. And the arguments, Stephen points out, and he spoke to some stellar lawyers, as he refers to them, suggested that it could have a possibility of success. But the fact that we are to be assured of life, liberty, and security, well, not having access to a family physician doesn't give you a good confidence of that. Also, it would be interesting if the court would expect that the Canada Health Act would define what the principle of accessibility means. Because accessibility is nice to be articulated in the act, but if in fact individuals are getting their cataracts and hips and knees done in institutions that are basically charging them for that service, that is not accessibility as have been intended from the communitarian perspective of Tommy Douglas. So there is something to be done here, but I think at the end of his article, Stephen said, who's actually got the energy to pull those people together? Colleen Flood has done some very good work, and she made a submission to the Royal Commission that Romano chaired. And as we know, there are the 5 principles of the Canada Health Act. But why don't we have the Canada Health Act amended that actually gives Canadians the right to access to universal care? I think Canadians think they have the right to access, but nowhere is that defined clearly. Also, you might be interested to know that you actually own your health records. 30 years ago, the Supreme Court of Canada had a judgment as a result of a case that was brought to it that in fact Canadians have a right to their own health data. But how many of you actually can say you have access to your own health data? According to the last review, I believe it was by InfoWay, 34% of you, which is a long way to go. Maybe we could even be clear about defining the criteria for comprehensiveness and portability. Now, we do know that intrusion into this space causes everybody's hair to go on fire. So we need to think about ways to leave it to the provinces to comply and monitor and report on the federal government to enforce those kinds of criteria. Now, this is here for the policy wonks. And so when you think of Canada's position as being the second worst healthcare system, you'd be wondering, well, why does a country like Canada have such difficulty not being at the top of the list? Well, we have 13 jurisdictions that have to work reasonably independently of one another to achieve these ends. So policy wonks know that there are different approaches to policy making. There's the policy cycle approach, there's the policy agenda setting approach, and then there's the policy stream approach, which John Kingdon arrived at. So the complexity here is simply that there has to be a confluence of problems and policies and politics having to come together into a window of opportunity before governments are mobilized to introduce legislation or implement changes. Now imagine 13 of these kinds of wheels turning at the same time in Canada, all with different budgetary constraints and with timeframes and with different political ideologies playing out within them. You can appreciate the complexity associated with moving this agenda forward is going to be challenging, which is why we're where we are at. But that's not necessarily bad, because what we recognize is that even though there's probably another 180 countries that are not doing as well as us, we should still feel very fortunate. However, how can we do things differently? Recognize the federal government cannot solve this crisis alone. It can create the vision, articulate the values and principles, and it can build consensus. But implementation is going to be at the provincial and territorial levels. Well, thank you, Dr. Gold, for having developed the vision, the values, and the principles. We now have that. And we have, from the evidence of the meeting in Prince Edward Island, a commitment from the Ministers of Health and the Federal Minister of Health that we will work on the digital issues. So it's going to take the voluntary effort of all of us in the community to respond to these challenges. And it's going to need trust, goodwill, and robust data and consensus building amongst us to be able to do it. So where should we put our efforts? Those of you that are on this call are probably involved in many of these, several of these organizations. We need those standards for health data and interoperability, and we can't do that in isolation. British Columbia cannot do it alone. It's going to have to work within a broader national and frankly global context in which many of the best practices and standards are emerging in. And the good news is you can contribute and you can lead and leverage the knowledge that emerges from these settings. Thirdly, education. With the rise of knee science in our social and political settings, we need to be able to do better in respect to having individual understand data right from primary to secondary, post-secondary education, and importance in health literacy. Citizen-facing universities and colleges are essential. Being focused only on undergraduate and graduate care and research is fine, but there's a whole community of citizens to which you have some responsibility to increase the knowledge base. And I refer here as well to the McKinnon Institute, which is a joint project of Monash University and in Australia. And what this institute does is it provides a primer and an education for all members of the parliament in Australia, as well as state legislatures, as well as municipal individuals, to actually come and learn about what it is to govern and not start from a blank slate in respect to knowledge base on how to influence public policy and do what's in the public interest. So supporting citizen science and having open science in another part of it, having industry as a contributing factor is important. And I still don't understand why the terms of conditions of federal, provincial, territorial agreements are secret, why they're not open and accessible to all of us so we can understand how we can have explicit and transparent monitoring and reporting on health system performance. We're getting towards the end. So tomorrow there is a meeting being hosted by CIHI, and Evan Affleck and his colleague from Alberta Innovates, Tim Murphy, are going to talk about the work that they've done in respect to interoperability saves lives. And I refer you to their report. Now, you have to register by today, the end of today, to be able to participate in this discussion. But it's going to be extremely important to begin developing the harm framework and determinants of health data interoperability, which we're trying to reach for in this country. There's something else going on that needs your attention. Bill C-27, which is the Consumer Privacy Act, Personal Information and Data Protection, and Artificial Intelligence and Data Act. Three pieces of legislation being integrated into one legislation having to do with the challenges that generative AI is going to be, that we're going to be facing in Canada. President Biden released as an executive order in October of last year the US approach to the development and use of AI. European Union released theirs in December of 2023. We are still in committee stage, which is both good news and bad news. One, the horse is already out of the barn, but there may be opportunities to learn from the experiences from the other jurisdictions. But more importantly, in looking at the 72 submissions that have been made to the committee of Parliament that's looking at this, there has not been one submission from the Canadian health informatics leaders and community. And I have to ask, why is that? Because they are looking for sound advice on how it is to advance this legislation that's going to deal with this challenge. So I put that challenge out to you. So in conclusion, Canada's vision, values, and principles for effective use in the protection of Canadians' healthcare data and information has been clearly articulated. We have a commitment from the Ministers of Health and the governments to move forward on the health data charter for Canadians. Governance is complex and challenging. We have to support our MPs, MLAs, civic leaders, senior bureaucrats to be immune or at least resistant to niche science pandemic, which is washing over the global environment. The future success of Canadian healthcare system is dependent on the use of health data. Truth knowledge require reasoned discourse and upholding principles that enable collective pursuit of truth in the relationship between science and power. And we need to better understand how to communicate risk and uncertainty, as Bob Evans reminded us. We need to aggregate the data and personal stories that illustrate the anguish, suffering, and mortality arising from our continual dysfunction. We have the knowledge and capacity to be performing as one of the top 3 OECD healthcare systems. We need to get past our parochialism. I encourage you to find ways to help us make a difference, to provide Canadians with the healthcare system that they deserve. Thank you very much. I'll finish with that, Elizabeth.